Your heart has walls. What if the infection starts growing on them? Welcome to endocarditis. Let us uncover infective endocarditis in this video. Defining the infective endocarditis. Infective endocarditis is an infection of the endocardial surface of the heart, most commonly involving the heart walls. The infection of the endocardial surface of the heart is called as endocarditis. It can also affect neural endocarditis and indwelling cardiac devices. Pathogenesis. Pathogenesis of endocarditis is turbulent blood flow across a damaged or abnormal valve causes endothelial injury. Exposure of subendothelial collagen occurs, deposition of platelets and fibrin occurs, transient bacteremia seeds the nidus and vegetative formation occurs. Basically, the blood flow which is turbulent that damages the walls of the heart. The subendothelial collagen and the deposition of platelets, fibrin, the thrombotic activities take place and the bacteria grows there and the vegetation are formed, that is the endocarditis. The vegetation. The friable masses of fibrin, inflammatory cells, microorganisms are prone to cause the embolism that can cause valvular destruction, abscess formation and systemic complications. There can be thrombotic causes which can lead to the blockage of the arteries and other complications. Mnemonic for it is NBTE, that is non-bacterial thrombotic endocarditis, the sterile precursor lesion awaiting bacterial seeding. There is a non-bacterial thrombotic endocarditis where a sterile lesion is waiting for bacterial seeding so that bacteria grow there and endocarditis occurs. Let us learn the two phases of endocarditis. That is the acute endocarditis and subacute endocarditis. This is the classification of endocarditis, acute and subacute. Acute, rapid, aggressive course often affects normal walls. It always affects normal walls, caused by highly virulent organisms like Staphylococcus aureus. It is fatal within 6 weeks. If it is untreated, it is fatal within 6 weeks, present with high-grade fever and sepsis. Now subacute. Subacute bacterial endocarditis. It is indolent. It is insidious in onset. Typically affects previously damaged walls of the heart, that is in rheumatic or congenital. Caused by less virulent organisms like Viridans streptococci. It is fatal within months to years if it is untreated. Presents with low-grade fever and constitutional symptoms. There is a mnemonic for the clinical features of endocarditis from Jane, where F stands for fever, R for Roth spots, O for Osler's nodes, M for murmur, J for Janeway's lesions, A for anemia, N for nail-bed hemorrhages, and E for embolus. The etiology and the host. The causative organism and clinical presentation depend heavily upon the host's underlying cardiac status and risk factors. Basically, the causative organism, the clinical features, it depends upon the host cardiac status, whether the walls are previously damaged or not, whether the person is having any risk factors like bacteremia, septicemia, or he was having previously any infections or not. In acute infective endocarditis, Staphylococcus aureus is the causative organism. In subacute endocarditis, the Viridans streptococci is the causative organism. and there is the intravenous route where the drug-associated endocarditis is also seen. In acute endocarditis, that is Staphylococcus aureus, most common cause overall. It is highly virulent, produces enzymes that destroy tissue rapidly, creates metastatic abscess, often associated with IVDU and healthcare exposure. Subacute endocarditis, where the Vigilant streptococci has low virulence, requires pre-existing valvular damage, enters bloodstream during dental procedures and slowly colonizes the damaged endocardium. Classic subacute endocarditis organism is Virulent streptococci. IVDU is associated with endocarditis, where typically S. aureus and predominantly affects the tricuspid valve of right-sided endocarditis. Septic pulmonary emboli are the hallmark. These are associated with the Pseudomonas and Candida and the chronic users. The pathology and the vegetation of infective endocarditis are: the hallmark lesion is the vegetation. It is a friable mass of platelets where the fibrin, inflammatory cells, microorganisms adherent to the valve surface. These vegetations are mechanically unstable and prone for the fragmentation. Now let us see left-sided infective endocarditis, right-sided infective endocarditis, valvular destruction and perivalvular extension. Left-sided infective endocarditis, where the vegetations on mitral and aortic valves causes systemic embolism. This systemic embolism can lead to stroke, splenic infarct, renal infarct and limb ischemia. Now right-sided ischemic heart disease, the vegetations on tricuspid valve causes septic pulmonary emboli, where the lung cavities, lesions occur, hemoptysis and empyema is seen in the lung. Valvular destruction, where the enzymatic degradation by bacteria, leaflet perforation, choroidal rupture, acute valvular regurgitation and heart failure is seen in the valvular destruction. Now let us see the perivalvular extension, where the infection spreads to annulus, where the ring abscess, fistula formation occurs, and the heart block, where the AV node involvement is mostly seen. Now let us see the clinical features of infective endocarditis. The constitutional symptoms are fever. It is often present in symptom in the infective endocarditis. Chills, rigor, night sweats, weight loss and anorexia, malaise and arthralgia are the constitutional symptoms. The cardinal or the cardiac findings are new or changing murmur in 50% of cases, signs of heart failure if valve is destroyed, and conduction abnormalities where the abscess can occur. Peripheral stigmata, where the Janeway lesion are the painless, erythematous macules on the palms, soles, and septic microemboli is seen. Next are the Roth spot, are the retinal hemorrhages with the pale centers. Immune-mediated vasculitis is seen. Osler's node are painful, tender nodules on finger and toe, immune complex mediated. And splinter hemorrhages are the linear subungual hemorrhages. Microembolic phenomenon is seen. Diagnosis is done by modified Duke's criteria. Definitive diagnosis requires two major criteria or one major plus three minor or five minor criteria are needed to diagnose the infective endocarditis. The mnemonic for it is B5, that is blood culture, echo, fever, immunologic, vascular endocardial predisposition and microbiological evidence. The major criteria are Positive blood cultures. First one is the positive blood culture where typical organisms like Viridans streptococci, Staphylococcus aureus or Hack group from two separate cultures or persistently positive cultures. Eco-evidence is the second major criteria where the vegetation, abscess, new partial dehiscence of prosthetic valve and new valvular regurgitation is seen. Minor criteria where predisposition is the first criteria, the underlying disease of heart or IVDU. Second is fever more than 38 degrees Celsius. Third is vascular phenomenon where the artery is embolized. Septic pulmonary infarcts or myotic aneurysms or Janeway lesions. Fourth is immunologic phenomenon like glomerulonephritis, Osler's node, Roth spots are seen. And fifth one is the microbiological evidence that is a positive culture for the bacteria. Laboratory investigations where we do blood cultures, echocardiography and hematology and biochemistry. Blood culture is the gold standard for the diagnosing infective endocarditis. Draw three sets of blood from different venipuncture sites spaced 1 hour apart before antibiotics. Each set includes aerobic and anaerobic bottles. If culture is negative, consider prior antibiotic use. And fastidious organisms are also checked. 3 blood cultures are done. Echocardiography where transthoracic echo and transesophageal echo is done. It is 95% sensitive for detecting the vegetations. In hematology, leukocytosis, normocytic anemia, elevated ESR, CRP, hematuria, and rheumatoid factor are always ruled out for diagnosing the infective endocarditis. Treatment strategies. The mnemonic for it is ASS, where the antibiotics, surgery, and stability are the three main things to treat the infective endocarditis. In medical management, we will give the empirical therapy like before culture results like vancomycin plus gentamicin, which covers MRSA, streptococci and enterococci, and targeted therapy after the culture sensitivity like for Staphylococcus aureus we will give oxacillin plus gentamicin, MRSA for vancomycin, Viridans streptococci with penicillin G or ceftriaxone, enterococcus like ampicillin plus gentamicin, and duration is for 4 to 6 weeks is given IV typically. Surgical indications where the heart failure, acute severe valvular regurgitation causing refractory heart failure, surgery should be done where the valves are destroyed. Uncontrolled infection, if the infection, the fever, bacteremia, despite of appropriate antibiotics, it is not healing. Prevention of embolism, to prevent the emboli, the vegetations and all are managed by surgery. Perivalvular extension where the abscess, fistula, heart block requires surgical drainage. Clinical takeaway from today's video is infective endocarditis remains a life-threatening condition where early recognition, prompt treatment are the difference between recovery and catastrophe. Suspect the cases early, act fast, apply Duke's criteria, and know when to operate. Most commonly, we should suspect the cases early by explaining the patient that he is having unexplained fever, new or changing murmur, infective endocarditis is still until proven. Otherwise, don't wait for all features to appear. Start the treatment. Act fast. Acute infective endocarditis progresses in days. Obtain blood culture immediately. Start empirical antibiotics and involve cardiology department for early diagnosis and treatment. Apply Duke's criteria. Systematically evolve major and minor criteria for the infective endocarditis and diagnose it. heart failure, uncontrolled infection, large mobile vegetation, surgical emergency, early surgical consultation improves the outcomes. Remember, the difference between acute and subacute infective endocarditis is speed and organ, the virulence of the organism. Treat fast to prevent irreversible valvular destruction. If you learned something today, don't forget to like, share and subscribe to the channel. Thank you.